And good morning or good afternoon to everybody who's on listening with us today. We're really pleased to have all of you join us because we're presenting the contents of a really big report attached to the Trauma, Gender, and Substance Use Project. I know many of you will have been with us over the 2 years, and maybe some of you are newer today or in the last little while, but we've had a really good project in so many ways, and this report is trying to encapsulate a lot of what we've learned and to give all of you a toolkit to keep and take with you in your future efforts. So we've called this new terrain because we really do think it is new terrain, and all of us at the Center of Excellence for Women's Health are quite excited about the fusion involved in this project, trying to integrate trauma-informed approaches and gender-informed approaches into substance use practice and policy. So today we're going to just cover what that means, give a few examples along the way, and show you a little bit about what's in the toolkit in terms of how you might take some of the little tools we've included here to further your own work, and then of course to talk about some of the evidence summaries that we've been doing all along. This project's had many parts, and it is all based on evidence reviews that we've done continuously throughout the time. As you know, we've had over 13 jurisdictions involved with us, and in all parts of the substance use response system. Here we are, it's Lorraine Greaves speaking right now, and then we're going to move along, the rest of our team, each sharing this presentation. So we'll go to Rose and Nancy and Natalie in that order. So what exactly is trauma, gender, and sex-informed approaches? The project, as I said, has taken 2 years. We've worked with a lot of different people at a lot of different levels of the system, from policymakers and program planners and people delivering treatment services or prevention or harm reduction. And we've tried to highlight just exactly what these two different approaches are in the interest of fusing them. And along the way, we've created quite a few knowledge exchange materials and resources, all of which are lodged on our website. And secondly, we've also done quite a few webinars along the way and communities of inquiry. Again, some of these recordings are on the website, so if you're interested, you too can catch up on that. The basic premise of doing a gender-informed approach to substance use is to recognize that both sex and gender matter, and that sex and gender are some of the most influential determinants of health. And this poster is a very handy one to get that point across. It's from the Institute of Gender and Health at the CIHR, which is the Canadian Institutes of Health Research, our major academic funding body in Canada. And this poster actually just kind of very clearly lays out the fact that gender is composed of many of the social and cultural aspects of our lives, and sex is composed of many of the biological and physiological processes that affect our bodies in particular and how our bodies respond. And how do they matter? Well, just in a wide variety of ways, as you can see here. When we say sex and biological attributes, we're talking about everything from metabolism to hormones, to one's anatomy, to one's reproductive life, and the different hormones and different phases that both men and women go through, to our gene expression, to the amount of adipose tissue we may have. And on the other side of the coin, gender really invokes all of our social and cultural roles, relationships, opportunities, or barriers that are put in front of us. It's what we're taught in family and community, and it's often cultural. In particular, gender can change over time because, as you can see, it's quite a moving thing. But, you know, the point of this project was to really focus on how these two issues matter in substance use and then merge them with a trauma-informed approach. And so it's worth considering these elements here. We do now know from the evidence that males and females have different responses to drugs. And these could be substances such as alcohol or tobacco or other kinds of drugs like cannabis or illegal drugs. It's clear that this is a pretty standard issue now. And therefore, when we're thinking about the treatment plan we might want to create, or if we're thinking just about interpreting the responses to a drug in terms of behavior or in the effect on the brain, we really do have to focus on this side of things. The consequences and impacts, it's clear from that list there under point 2 that there are many, many, many consequences of substance use. And a lot of these are negative in this list. As we know, we're often in our lines of work trying to deal with some of these issues that are sometimes side issues or sometimes result from drug or substance use, or sometimes are there before substance use occurs. And so these impacts, too, are gendered. It's clear that women and men may experience very different impact in terms of poverty and homelessness in particular, also in terms of the kinds of sex work, for example, or other forms of deriving income might be experienced in terms of keeping a drug habit going. Prevention and treatment, similar sorts of things. When we're in our work trying to create campaigns, or if we're trying to create treatment programs, we need to recognize that there are both sex and gender impacts and that they're very complex and multiple. And then, of course, reproduction, fertility, and parenting. This affects both men and women, boys and girls. It's often, though, focused on women in their roles as either pregnant women or new mothers in particular. But we like to broaden that view and say, you know, when you consider sex and gender, this affects everybody really in terms of whether or not they are interested in having children or keeping their children, or whether or not they are caring for children. So these are some of the very many issues and how it works in terms of sex and gender affecting substance use. This is one of the concepts we introduced in this project called gender transformative approaches. And this is more complicated in some ways because it forces us to think about not just including sex and gender and doing that properly, but also thinking about how we do that, and whether or not the way we're including sex and gender in our response to individuals and groups is going to contribute to better gender equity on the right, or we try to avoid this, maintain gender inequity on the left. And you can see that this chart sort of indicates that we can make a choice about that. We can, for example, in the second column, choose to be gender blind in our programming or in our messaging, ignoring gender norms entirely. We could, on the other hand, choose to be gender specific, looking at the fourth column, where we would actually acknowledge gender norms and consider their effect on women and men, and quite possibly manipulate elements of our program or our message to respond to that. And that's somewhat better than being gender blind, but one of the things we've challenged each other to do in this project is to try and think about being gender transformative. And that's the last column, where we actually look at the cause of some of the gender-based health inequities that affect everybody in some way, and work to transform those harmful gender norms and roles and stereotypes in the context of what we're doing when we intervene or when we create a prevention program, for example. And this shifts us a lot closer to actually tackling some of the root causes of gender inequity, and hopefully in our work in substance use contribute to better gender equity. So this is, I know if this is a first for you today, this is kind of a complicated concept, but it is something we've talked about over the 2-year period, and it is in this toolkit called New Terrain, so you can study this chart and think through how your own efforts at the moment might be mapped onto this particular diagram, and think through perhaps how you might nudge your efforts a little bit to the right. We consider this a new frontier. It's a process. It's a challenge. It's not always easy to do this, but we do think it's very important for all of us to think about that, especially when we see so many gendered inequities in the substance use field at the moment. Now, many of you may be familiar with what we mean by trauma-informed practice. In fact, many of you may have been practicing this way all along, and maybe the sex and gender was newer for you. But it is worth reviewing, and this is also in the toolkit, New Terrain, that basically trauma-informed practice means that we integrate an understanding of the experiences of violence and trauma into all aspects of our service delivery, all aspects of our programming or policy making, in our individual interactions, in every way. Even the physical plant in some of our offices or agencies comes under scrutiny under this. And it basically assumes that everyone at some stage may have experienced trauma or violence and may be recovering in their own ways from this. It does not mean that they must disclose this for us to respond properly. It means that we create a safe environment for everyone, so it's more of a universal precaution. And the goal, obviously, is to avoid re-traumatization, and more than that, to actually support safety, choice, and control as people come forward for assistance or for information. And here's a diagram from New Terrain, and this, some of you may have seen before, really sorts out the basic principles on which trauma-informed practice is built. An awareness, the creation of safety and trust, the creation of a situation where clients or patients or participants feel that they have choice and that are in fact collaborating in what they're doing with you or with your agency. And of course, last but never least, builds on strengths that clients and participants bring with them. And so you can see it's a very positive and safe kind of approach. And it's something that we encourage every single member of a team or an agency to actually think through and become trained in. Whether you're the receptionist or the cleaner or the CEO or the frontline worker, really should involve everybody. So, as I said at first, what we've tried to do in this project is actually merge these two approaches, because we recognized early on that trauma and violence are also gendered. And it's very clear that women and girls experience disproportionate inequality of all kinds, actually, social, economic, physical violence, sexual assault. This is true pretty well all over the world in different ways, shapes, and forms. And boys and men are more likely to experience other forms of trauma. And, you know, these differences we feel need to be taken into account. And all of this, of course, impacts and interacts with a variety of other features of our lives, whether it's sexual orientation or ability or income or whatever it might be. All of these things, when you think about it, affect our access to substance use and treatment and how we actually receive and access resources. So the benefits of doing this approach, trauma, gender, sex, merging them together, are listed here. We think there may be more in the future as the evidence builds, but we're certainly encouraging people to think about these as arguments for integrating these approaches in your activity. And these are arguments that you can make with your colleagues, with management, as you create new initiatives, as you apply for money and write proposals. These are all the kinds of arguments that you can make that are, in fact, benefits of taking this merged approach. So that's our introduction and a little bit of a review of the past 2 years. And I'm going to hand it over now because we're going to talk a little bit more about the next section of the toolkit.
Great, thanks, Lorraine. So the section 2 of the New Train Toolkit provides a range of examples where trauma of a sex-informed initiative is Canada's low-risk drinking guidelines. These guidelines were released in 2011, and they were among some of the first sex-specific guidelines in the world. They include evidence-based recommendations for alcohol consumption intended to reduce the harms and safety risks associated with drinking. They provide different recommendations for men and for women. These recommendations are that women consume no more than 3 drinks on any single occasion and stay within a weekly limit of 10, whereas it's recommended for men that they consume no more than 4 drinks on any occasion and stay within a weekly limit of 15. And these different levels are based on research that shows that women in general are more vulnerable to the effects of alcohol use. Biologically, on average, women weigh less and therefore reach higher blood alcohol levels compared with people who would weigh more. Women also have less adipose tissue, which causes alcohol to be absorbed more slowly and affects how long it takes alcohol to wear off. And women have less water in their bodies to dilute alcohol. So even if a woman and a man are the same weight and they drink an equal amount of alcohol, on average, a woman's blood alcohol concentration will be higher. Women also have lower levels of alcohol dehydrogenase, which is the enzyme that breaks down alcohol, causing it to stay in a woman's system for longer. So that evidence on the sex differences have informed these guidelines and led to the different recommendations for male and female. The Mothering Project is a trauma and gender-informed program that's located at the Mount Carmel Clinic in Winnipeg's North End. They provide community-based prenatal care, parenting and child development support, group programming, advocacy, and addiction support for vulnerable pregnant women and new mothers. The program is both trauma and gender-informed and offers relationship-based support with a large focus on Indigenous culture. The program has a low barrier intake, which is very trauma-informed and focuses on building positive relationships. And it is harm reduction oriented, as they recognize that many people have deeply embedded issues in their lives and change does not happen instantly. The program works with families over a long period of time, officially until the children reach the age of 5, but it can be extended. And they support women who are parenting full-time, part-time, or who have their children in foster care or living in extended care. And they have an on-site daycare program and infant care program, which has allowed a number of mothers to keep their children out of care. They have a Women's Advisory Council that acts as experts to inform all planning, development, and implementation of the program. And as I said, the programming provides addiction counseling support, as well as culturally informed trauma counseling and support to navigate child and family services. As a large portion of the clients are Indigenous, as women are ready and if they're interested, they're able to participate in opportunities to learn about culture and Indigenous identity. They have activities such as smudging and outings to collect sage and a drumming group. The image here is a picture of their brand new ceremony room, which is a really lovely space that has proper ventilation for smudging, a chair there for an elder, and it's a beautiful circular room where they can practice their drumming group. In general, the space at the Mothering Project is very homey. It has a very safe feeling. The kitchen is not industrial. It's very much like one you'd have in your own home. So this is an example about improving gender equity, and that's in alcohol and pregnancy awareness campaigns, or FASD prevention campaigns, FASD being fetal alcohol spectrum disorder. So many traditional approaches to FASD prevention were aimed entirely at women. They often used fear-based messaging, and they often suggested that women who drank during their pregnancy were uncaring or irresponsible. And recently there's been increased recognition that these fear-based campaigns have limited effectiveness and that they can lead to feelings of shame and stigma for women who have difficulty stopping their alcohol use during pregnancy. And this shame and stigma can also act as a barrier for women who are struggling with addiction for accessing prenatal care or supporting their support for their substance use, so that they actually maybe were doing more harm than good. So some more recent campaigns are using a gender transformative approach, like Lorraine was describing in her section. So in these types of ads, they challenge traditional caregiving roles of men and women so that as to share responsibility for reproduction and childcare. It's acknowledged that women's substance use before and during pregnancy is strongly influenced by her partner and peers, so that promoting a wider involvement, including campaigns aimed at men, can be gender transformative by role modeling equitable and healthy relationships. These campaigns can support men as fathers and caregivers before, during, and after pregnancy, and they provide an opportunity to shift gendered attitudes about personal responsibility and the expectations of men and women and ways of caring for each other. In addition to challenging traditional norms about the roles of men and women during pregnancy and parenting, health promotion campaigns are increasingly representing diverse families and the way of parenting and caregiving. Moving forward, this could include showing pregnancy and substance use in different groups such as single parents, adoptive families, lesbian couples, or pregnant transgender men. Not only would this help reach all members of society, it also recognizes that gender intersects with other societal factors. And a final example is the Jean Tweed Center, which provides substance use, mental health, and problem gambling services to women and their families across Ontario. The work at the Jean Tweed Center is informed by an understanding that gender and other social determinants of health impact substance use. For example, they have a fully licensed therapeutic child development center on site for mothers. The center recognizes that many women who struggle with substance use or problem gambling have experienced some type of trauma in their lives, and they may use these behaviors as a coping mechanism. So as a result, all of the services at the center are trauma-informed. They have an understanding of the role of trauma in women's lives, which is considered in all programming, and all of the services are offered in a safe and caring manner. They released guidelines for trauma-informed practice and women's substance use service in 2013, and the principles in this guide guide their current work and their programming. The center offers residential and day program, outpatient program, including family and trauma counseling, individual counseling, and continuing care. So quite a lot of flexibility in the range of services that are available. And they also provide outreach services that are available for pregnant and parenting women, as well as women with concurrent mental health issues or women who are involved in the criminal justice system. Recently, the Jean Tweed Center has continued to develop their services in order to better meet the needs of transgender people. These initiatives have included the development of an inclusion policy, staff training on access of services for trans women, creating more welcoming spaces, including private non-gendered washrooms and displaying trans-positive materials in their waiting rooms, and the reflective practice of reviewing their language as well as their current program curricula. Now I'm going to pass it on to Nancy, who will talk a little bit about how we can incorporate these principles into developing or evaluating other programs.
Hi, everyone. Yeah, so, part of our work with all of you across the country has been thinking through kind of not only the what of bringing a trauma and gender analysis and a trauma-informed analysis to your work, but also the how. And many people have approached us to talk about, where do we start? And so we've included a couple of quite simple tools in this guide to help you think through this process of fusing trauma-informed practice and gender-based analysis, and to get started in lots of ways using a pretty straightforward three-step process. And I'm just going to walk through those 3 steps now with you and give an example that we had the opportunity to do with an organization in Saskatchewan in the course of the project. So in all, gender-based analysis type work, such as the GBA Plus at Status of Women Canada website, et cetera, almost all of them start with this idea of beginning to think through what evidence is there already about the topic that you want to study. So if you're designing a program, you can be thinking in the section gender analysis part of what evidence and research is available that describe sex, gender, and equity factors related to the programming or policy that you're beginning to do. And, you know, in the next section, Natalie's going to introduce you to a bit of the work we've done and included in the guide that can get you started on some of that evidence that is currently available. And I think always as we think through sex and gender-based analysis, we do have to ask that second question of what data is missing, and who might we consult to add to an understanding of how we need to develop this programming. And are there specific sex or biological issues in terms of the impact of a substance on men's, women's, and other peoples on the gender continuum on the body aspect of the work, and thinking about how you can make your programming reflect that. And that could be, such as Rose mentioned with the alcohol evidence, of really making sure that women understand the reasons behind the recommendations in low-risk drinking, et cetera. And the same thing, you know, applies on the trauma-informed side. Do we have evidence about how trauma and violence is related to the issue? Are the different knowledges and experiences of the populations affected by the policy a part of the evidence? And how do we bring that in, the understanding that there's more than research evidence. There's, you know, clinical wisdom and indigenous traditional knowledge, et cetera, that we can bring in as evidence behind our programming design and policy design. And of course, learning from others who've walked ahead, who's already been working on this, such as the examples that Rose mentioned of getting help from others who figured out some of these things and have already put some guidance together. And the second step, after thinking through, you know, do we have what we need to know to make an evidence-informed program, is to really think more deeply about the who it is that we're designing programming for and with. And really, in the case of trauma, think about what groups may experience the impacts of trauma in different ways, and Lorraine talked a bit about that in the opening section. And are we in some ways going to address or reinforce inequities? And thinking of that continuum that she raised about, you know, are we exploiting or are we actually transforming inequities as we're designing our programming? And what kind of structural conditions are in play that we need to directly address as we're designing this programming and policies? And I think, you know, as we think about homeless programming, you know, how do we bring trauma and gender into the housing first kinds of programming and other examples such as that as we're doing this work. And, you know, have we thought through in terms of the gender health effects and social context and consequences for the gender group or groups that we are trying to work with? And, you know, we didn't talk a lot about this, but we do in the guide about how gender and sexual orientation are often confused or conflated in people's minds, and really thinking about how these other dimensions of sexual orientation, age, culture, race, et cetera, are really also being taken into account, even as we consider sex and gender influences on the issue. So we're trying in some ways to help you think about gender and sex as determinants of health, and at the same time recognize that they're not the only determinants of health, but they're often ones that we have ignored in the context of designing substance use programming in Canada. And this is our chance to, work differently in that way. So wanted to give an example of where we have been able to bring this into our work. And in the guide, we provide an example on page 28, using the idea of how might we think through a trauma and gender-informed approach to aftercare for women. And we had the great privilege in the context of this project to work with the Family Treatment Center in Prince Albert, Saskatchewan. And on our website, you'll see the results of us walking through this fused trauma and gender-informed approach with them in thinking through how might you build an aftercare network. And so you can download the whole document. But you can see that we thought through the multiple areas that might be important in terms of the evidence for what are the physical health needs for women in aftercare. And we looked at that research. What are the kind of practical supports and barriers to housing and other things that women may experience in the aftercare context? What are their needs for relational growth and change in terms of the parenting and custody issues, and maybe going a bit farther in terms of getting support to explore how trauma has intersected with their substance use over time. And continuing around the circle, thinking about the cultural needs of Indigenous mothers in the aftercare period, and how might those connections be supported and enhanced. And of course, really thinking about our work in the addictions field and how our outpatient counselors in the communities that women return to really able to respond well. So you can see that this idea of women-centered, trauma-informed, harm reduction, equity-informed are all bound together as we did the look for evidence and thinking through this particular population's needs, and then thinking about an aftercare network that could be built that really responds to these needs. And I just wanted to mention that those words around the edge as well of meaning, purpose, belonging, and hope also really reflect the Indigenous wellness framework that the Thunderbird Partnership Foundation and Colleen Dell and others identified in the course of the Culture as Healing project. So I think it's a great example, and really we continue to work with the folks at the Family Treatment Center in making this, this analysis that we started with a reality in terms of an aftercare approach for women. So that's an example of trying to use the tool and bring the tools into practice. So I'm going to turn it over to Natalie now.
Part of this project, we searched the academic literature for evidence on sex, gender, trauma, and substance use. And then we developed summaries for each of these 5 types of evidence. So you'll find these summaries in the back of the report, and they're presented for each of 5 groups: women, men, girls, boys, and trans or gender diverse people. So I'm just going to briefly go through and provide an example from each of these categories. So an example of how gender influences pathways to substance use includes evidence on the differences between girls and boys in risk factors for initiating substance use and also protective factors. So, for example, we know that girls more often use substances to manage stress, depression, negative emotions, and they're also more likely to begin using substances if they have an intimate partner who's also using substances. So what this means for policy and practice is that some components that might be particularly useful in prevention approaches might be building skills around coping, communication and relational skills, managing stress, and also peer refusal skills. Sex and biological factors also affect substance use. So as has been mentioned, women are more vulnerable to the harmful effects of alcohol use. Women are also more vulnerable to the impact of smoking and also exposure to secondhand smoke, in part due to the influence of sex hormones and also women's relatively smaller airways, so anatomical differences. Secondhand smoke exposure has been linked to risk for breast cancer among young women. So some examples of how this might inform policy and practice are those sex-specific low-risk drinking guidelines that were mentioned, and also something that's been published on by our colleagues at UBC Okanagan, which is the development of messaging that's tailored to girls and boys, women and men, to increase awareness on the links between secondhand smoke and breast cancer among young women. So for an example of how gender and sex influence consequences and health impacts of substance use, we can look at opioid use. So we know that men are more likely to increase their opioid use alone, so engaging in these riskier substance use patterns. And they're also more likely to die due to an overdose, an opioid overdose, particularly fentanyl-related poisonings. So in 2017 in BC, around 80% of overdose deaths were men. So an example of how this can and has informed policy and practice in Canada is in the increasing availability of safe consumption sites. So this allows to promote safer use and also reduce related harms and deaths. Gender and sex also impact substance use treatment and prevention outcomes. So as mentioned, trans people experience very high levels of stigma and discrimination, and this can really negatively affect their access and response to services. So some ways that services can become more transgender inclusive include creating really welcoming and inclusive physical environments, and also engaging trans people in informing and developing programming. And gender also intersects with trauma-informed approaches. So for example, among boys, we know that physical abuse and witnessing of violence is both a pathway to and a consequence of substance use. So in practice, this really highlights the need for all levels of services to integrate trauma-informed principles and to really increase awareness among both providers and boys who are accessing services about the links between violence, trauma, and substance use. So yeah, that's a little, just a little summary of what you can find in the evidence summary section, and there's a lot more evidence in the back of that document when you download the resource, as well as all of the references in case you want to look into these studies in more depth. And we've also made this evidence available in another format. So if you go to our website, you can download 50 cutout fact cards with key pieces of evidence also from the academic literature on sex, gender, trauma, and substance use. So these are designed to be used for training and also promoting conversation and discussion about the integration of these approaches. And there are also a lot of other project resources available. If you go to our website and look under featured projects, the Trauma, Gender, Substance Use Project, you'll find guides, resources, evidence review summaries, and also all previous webinar recordings there. And of course, today, the newly released new terrain you'll find there. So we hope you'll all download it and share it and use it and find it of great benefit to your work and your practice.
So thanks, Natalie. I don't see any questions that have been typed in. So maybe we will just leave it there for today and hope that people stay in touch with us by email and really have a chance to dive into this document and think through how to apply some of these concepts and tools in the context of their work. So thanks, everyone.
Thank you.